The lateral femoral cutaneous nerve, or LFCN, arises from L2 to L3 and is a purely sensory nerve. It emerges from the lateral border of psoas major, crosses the iliacus muscle, and travels toward the anterior superior iliac spine, or ASIS. It then passes under, over, around, or occasionally through the inguinal ligament before becoming superficial. It is easy to see why the nerve passing through the ligament or superficial to it could lead to problems. When the nerve runs under the ligament, which it does in the majority of cases, it goes through an osteofibrous tunnel comprised of the inguinal ligament as its roof, the ilium as its cradle, and the fibrous attachment of the fascia lata inferiorly. This tunnel is tightened by hip extension, and most patients, therefore, will be more comfortable in a hip-flexed position. This anatomical variability is important clinically, as it contributes to its high susceptibility to compression injury. Clinically, LFCN entrapment is known as meralgia paresthetica. Symptoms include burning, tingling, or numbness over the lateral thigh, including the trochanter and the path of the ITB. This can also variably include the anterior thigh. As a purely sensory nerve, there cannot be motor deficit with this condition. It is often aggravated by tight clothing, belts, or prolonged standing. Various occupational factors can be at play, and abdominal surgery, pregnancy, and birthing. A child can all cause issues. Key compression points are near the ASIS at the inguinal ligament. The entry and exit from the osteofibrous tunnel distal and lateral to the ASIS, and as the anterior and posterior branches come around the trochanter, and then run on either side of the ITB, and as the nerve terminates near the lateral knee. In terms of surface anatomy, identify the ASIS. Move approximately 1 to 2 centimeters medial and inferior to deliver a dose over the top of the nerve at that point. With one finger on the ASIS with the patient on their back, draw a line 45 degrees in a distal/posterior direction. At around 3 centimeters, you will palpate a small hollow. This is the exit point of the osteofibrous tunnel of the LFCN, and can take a small repository of 3 milliliters of injectate at a depth of approximately 15 millimeters, which can be achieved with a 12 millimeter needle. Then move the patient to lie on the contralateral side, around 5 centimeters away from the ASIS and generally directly superior, cephalad, to the trochanter, are 2 spots where the branches of the LFCN separately punch through the fascia lata, and these usually will need 1 milliliter each, if tender, at a depth of 5 to 8 millimeters. The nerves pass either side of the trochanter, and the bony edges should be palpated for painful spots. Follow the nerves down to their terminus. The posterior branch finishes near the fibular head in a trident formation, with one middle leg over the fibular head and one passing forward and one posterior to the head. The anterior branch usually stops sooner, around 10 centimeters before the knee. Give any sensitive spots 1/2 to 1 milliliter at the usual subcutaneous depth. Due to variability, clinical feedback during palpation is essential. Here is a map of a fairly common number of points to inject in a long-standing case of ITB pain. For educational purposes, here is some ultrasound imaging in transverse of the LFCN around 3 centimeters distal to the inguinal ligament. Note the presentation of the nerve in its fascial layer and the musculature between which it sits, and a graphic representation of this in cross-section at the same level.